Good evening. Welcome to this meeting organized by Citizens for Quality Healthcare. I'm Ann Davis. I'm a member of the Health Sciences Association, and I am your MC for the evening. Citizens for Quality Healthcare is an organization of North Island residents formed in 2006 to bring together people from all North Island communities to advocate for improved hospital facilities and prevent any reduction in acute care services, and to keep our hospitals publicly funded and the care publicly delivered. They were instrumental in organizing opposition to the 2006 VHA plan to replace the two hospitals in Comox and Campbell River with one regional hospital. From the onset, they have been aware that privatization was part of the VHA agenda, and they are now taking up that fight in earnest. The building of a new hospital is one of the biggest projects to be carried out in any community, and it's one that will be there for many years. It's fair to say that every member of the community will, one way or another, access the services of that hospital, probably many times over. So when faced with this new to us model of a P3 hospital, it's important that we understand what that means and the implications for our community. We're fortunate to have a knowledgeable panel this evening that can provide that information. So I would like to introduce Dr. Vanessa Bursick. Dr. Bursick is an executive board member of Canadian Doctors for Medicare. She is a family doctor from Vancouver, a researcher in the UBC Department of Family Practice studying equity in healthcare, and she is someone who has spent years navigating both the public and private systems as a patient. Next, I'd like to introduce Stephen Elliott Buckley. Stephen is a trade and healthcare policy researcher with CUPE and with the Hospital Employees Union. He mainly concentrates on expanding Medicare and fighting privatization, which sounds like a dream job. He also writes the back page commentary in Our Times, Canada's independent labour magazine. Thirdly, I would like to introduce Barb Biley. Barb is a member of Citizens for Quality Healthcare. She is a healthcare worker at St. Joseph's General Hospital. She's a Hospital Employees Union alternate vice president for Vancouver Island North. Vanessa will speak first on the broad issue of privatization in healthcare. Stephen will be our second speaker on P3s, a brief history and the experience in BC. And thirdly, Barb will speak about the local experience. Following the panel, we'll open the floor to questions, comments, discussion. And during that transition period, there will be buckets passed because there are costs for this evening. And if you can contribute something, that would be very much appreciated. So first up, I'd like to welcome Dr. Vanessa Bursick.
Privilege to be here amongst such an engaged group of citizens. I wish that we had a group like this in Vancouver. We're all in this together, and it's been an absolutely wonderful experience for me coming here, so thank you all for coming. So the goal of my part of the presentation is, I want to not bend over, is to paint a picture for you of the scope of the problem. I have a lot of information to present, and what I want you to do is just understand the trend that's happening. Don't feel like you need to retain all of the information. I just want to paint a picture for you of the landscape surrounding the P3 issue. So some of the issues that I'll be covering, the unsustainability myth of healthcare is one that justifies the shift towards privatization. So we have to talk about that. When the shift hits the fan, you'll find out what that is. Briefly, there's a big issue going on in the courts right now, which is the Brian Day legal challenge, which I really think that you should know about alongside the P3 issue. And then the evidence for or against for-profit medicine, and other shifts that are happening in more positive directions in healthcare. So the crisis in healthcare. Let's briefly start by looking a little bit at the history of Medicare, because this is the foundation that we built, that we are standing up for today. So let's remind ourselves of that to start. The 5 principles that you see on the right side of the slide: universality, accessibility, comprehensiveness, portability, and public administration. And the key role of the federal government here, who have recently been stepping away from their key roles, which includes some direct healthcare delivery, but very much enforcing national standards, setting a trend for leadership under which the provinces act as single payers to deliver their basket of services. So what are the impacts of Medicare on hospitals and on doctors? So over almost 30 years, Medicare was slowly built. Saskatchewan was the first province to first cover hospital care, to second cover doctor care, and then eventually the other provinces came on board. The goal was that patients would no longer have to pay for these services, because the reality was people were losing their savings and losing their properties to pay hospital bills. And that's exactly what was about to happen to Tommy Douglas. The choice was between a leg amputation or a surgery he couldn't afford. Fortunately, he was able to have the surgery, but he definitely let that come forward in his voice for Medicare in Canada, that experience. For doctors, this is important as it relates to the Brian Day case. So physicians were then given the opportunity to opt in and out of providing care under the public system that was being introduced. If they opted out. So you could either bill the government for the services you're providing, or you could bill the patients. But if you're going to bill the patients, you needed to bill no more than the amount that you would bill the government for. So it creates a disincentive to work outside of the system. But underneath, despite that billing story, doctors basically could run their own practices how they saw fit. That's why we see all kinds of private offices where doctors are essentially their own boss. So, a bit of background, the challenges that we face now in this system. You can read the list for yourselves. There's lots of them. These are all very real challenges. And you'll notice the last one, a challenge is the concern that costs appear to be growing, not the fact that costs are growing themselves. And then that list gets inflated by the media and by a lot of folks who work for government as well into these 4 big issue items, big ticket items. All of them basically can be dispelled, and I'll go over them very quickly in the next slides. So, rising costs in healthcare. Yes, healthcare is getting more expensive, but it's not getting as much more expensive as we think, in that it's actually mostly the private portion that has been growing. Really, the biggest contributor is drug costs, and everything else has been growing, not out of proportion with what we expect with inflation, and even the aging population isn't as accountable as we think. Tax reductions also make the pot from which we're drawing smaller, and so you get this created crisis where in the last 10 years, 6% of the GDP has been cut in tax revenue. So that's foregoing about $10 billion annually in revenue. So then everything becomes underfunded, you end up cutting some services, inefficiencies get created in the system, and then the crisis evolves. Briefly on aging, looking at the 3rd bullet point, aging is projected to account for only 1% of cost increases going forward. Going to the 1st bullet point, you'll see we understand that as people get older, they use the healthcare system more. This isn't something new that's happening. What's changing is that Medicare was founded as a way to cover hospital-based care. And as people are getting older and living well lives with chronic conditions, they're still heavily depending on the acute care system without the kind of community care systems in place that would better serve them. So you end up getting 57.5% increase in visits to the doctor, so that people can stay well. And when that is not available in the community, people get filtered through the hospital, and then the costs end up disproportionately affecting the acute care system, which is further strained. So it's about, when Medicare was founded, looking 50 or 60 years back, it very much was a system where most people did depend on the most significant portion of care to be received in the hospital. And that is changing quite a bit. And so we haven't really done anything to address that. And so that creates a crisis. These next graphs, I just want you to look at the lines, look at the trends. That's the important message here. This is looking at provincial health expenditure over GDP in the last 30 years, relatively stable. However, healthcare spending is increasing in all countries, and you can see various countries listed here. The top line is the United States, which, as we all know, has a two-tiered system, which is very inefficient, and as you can see, costs are increasing faster there than anywhere else. These pie graphs show how healthcare spending has changed from 1975 to 2011. The important thing to look at on this slide is the blue arrow. You can see it pointing to the portion of the pie represented by pharmaceutical costs. And that's the one portion of the pie that has increased substantially in the last 40 years. The rest of the slices of the pie have all increased pretty marginally, as we might expect them to. You'll also notice the biggest piece of the pie, the other red color, the really dark red color on the slide, is the hospital budget. And so that has actually shrunk as an overall proportion of healthcare dollars spent. As I mentioned, drugs are the biggest cost driver. Millions of dollars, you can see on the y-axis, on the vertical axis. This is sort of self-explanatory. Impact, there's been a lot of personal income tax reductions as well, but this slide is pretty dramatic, just showing the impact of corporate tax reductions. And just to give you an idea of the scale, on the left, those numbers represent millions of dollars, so we're looking at really significant amount of revenue loss. But costs are increasing, and we can't deny that, and it will keep increasing. So what are we going to do about it? And this is the really important question that we need to look at, because there's really only 4 options here. So in the red text, the numbers 1 and 2 are not really the direction we want to head, and numbers 3 and 4 is the direction that we want to head. I mean, if you have to start to contain costs, there's just not a lot of options we have before us. You either provide less services with the money you have, you provide services to fewer people. Neither of those are in keeping with what we want, what is ethical and humane. And numbers 3 and 4, or we improve efficiency, reduce costs, and raise additional revenue. Those are our options. So when the shift hits the fan. So what is the shift? The shift is coming from this place of this sense of unsustainability. And this is something that, although it's not substantiated by the data, it has become a rhetoric that we all just believe in Canada, that our public healthcare system is unsustainable. It's not true, but the shift that results from it is towards a two-tiered system. The rich, who have louder voices, generally, including in the Dr. Brian Day case, which they say, well, how is it constitutional for me to not spend my hard-earned money on my health? I can spend it on anything else. Why can't I spend it on healthcare? The public system is broken. It can't be fixed. It's unsustainable, once again. Public hospitals are inefficient. This idea that competition, is going to be one of the solutions. And just going back to the previous slide, if we're looking at competition, you can see how numbers 1 and 2 might play out, because certain institutions might decide to deliver one service, which are easier to deliver, easier to profit from, easier to show that your costs are less. So you make it over-provision of some services in this, if competition is increased in the system, and under-provision of the services that are harder to deliver. So that creates inequities. Anyway, back to the shift. The aging population is a myth that we already spoke about, and that the answer is a two-tiered system. The other thing that plays into this shift is the Chaoulli case that was ruled upon in 2005. The Quebec Charter prevents the government from banning private insurance where the public system is inadequate. That was the ruling. But even the judges who ruled that there was a violation of the Charter, in that a person's rights were being violated if they were not jumping the line, if they're not able to pay for care that they were not able to receive in the public system, even the judges who ruled that that was unfair, didn't conclude that everyone should be able to buy private insurance, only in the case that somebody was in a dire situation. And I'll read you a statement from the justices who ruled in this case, who expresses that it was a particular situation, but of course, the law is now starting to be challenged in terms of, is it fair for us to have Medicare, which is dangerous. But anyway, this is what they said. In a public system founded on the values of equity, solidarity, and collective responsibility, rationing occurs on the basis of clinical need rather than wealth and social status. Patients who are in greater need of health care are prioritized and treated before those with a lesser need. For these reasons, it is not arbitrary for Quebec to discourage the growth of private sector health care. Prohibition of private health insurance is directly related to Quebec's interest in promoting a need-based system and in ensuring its viability and efficiency. So very much reinforcing the values of Medicare, despite the ruling, because people know that as soon as the legal precedent is set that private something is allowed to be offered, then the floodgates can open. So when the shift hits the fan, what's the fan? The fan is basically about the federal government walking away from responsibility on healthcare in Canada. You might remember, maybe not, just before Christmas, the Harper government announcing a few very scary things in healthcare. One was going back to per capita funding and canceling equalization payments between the provinces, meaning that some provinces raise more revenue than others, like Alberta, and some provinces just don't have the population to raise enough revenue to cover health services like PI, for example. And instead of the money going back into a central pot and being redistributed according to need and equitable principles, it's just per capita now. So that creates great inequities between the provinces. The other thing that they announced, which sounded gentle, I guess, at the time, which is the funding plan for the next 6 years that they announced in terms of escalation of funding. And numbers aside, what was worrisome is that they said, here's the money, and that's all I'm going to give you. And the provinces had a mixed response, but what's very worrisome is that we use those fiscal transfers from the federal government to keep the provinces on track with the direction we want healthcare to go. So that's the purpose of the Health Accord, which is renewed every 10 years. So the next time it'll be up for renewal is 2014. The federal government said, no, let's leave it to the provinces. Give them their autonomy. And without that leadership federally, and with increasing inequities in the funding between the provinces, you end up getting provinces reinventing the wheel and trying to do things on their own 2 feet without a plan in terms of moving towards, having a 10-year goal of where you want your health system to be makes sense. Doesn't mean that the health accords have always been perfect, but since when do we throw out the baby with the bathwater? So there's some really dangerous things happening in terms of the federal government stepping away from leadership. And what that does is it leaves gaps in the system. When you don't have strong leadership, it leaves holes. And we all experience those as doctors and patients and health providers and citizens. And when you leave holes and you're not enforcing the Canada Health Act and you're stepping away from leadership, you get for-profit care and for-profit institutions creeping into the system. And as this has been evolving over the last 10 to 15 years, especially in BC, it becomes almost the norm. That you've got a few for-profit clinics, you've got some P3 hospitals. Is that really a problem? We still have the public system here. But what it does is it's this concept of creeping normalcy. that something that is actually very bad policy ends up creeping into the system simply from lack of leadership. So, what's going on with the Brian Day case? So as of 2010, there were 130 for-profit healthcare clinics in Canada. So this is becoming a much bigger problem than a government that's stepping away from leadership would like to admit. 89 of those, and 29 in BC, were found in breach of the Canada Health Act's criteria regarding universality and accessibility. They were either selling medically necessary procedures and charging patients for them, or selling two-tiered care, meaning selling faster access to the system than people would get in the public healthcare system. This is their side of the story. Sounds lovely. Private surgical centers, I have to put on a special voice for this, I feel like. Private surgical centers allow doctors to assist patients who do not want to wait months for a surgery or an MRI scan. Who wants to wait months? Doctors bill MSP for the performance of a surgery, same as if you're in a hospital. The surgical center fee, paid by the patient, is to cover the cost of having the facility open, allowing them to get help sooner, in many cases, improving quality of life dramatically. This plays out in a few ways on the patient side of things. Here's a dialogue recorded by the BC Health Coalition in their 2010 report. My doctor says I need knee surgery. Can I buy it from your clinic? Yes, but you need a consultation with the surgeon first. How much does it cost? For the consultation, it's $385, and then if you need surgery, it's $7,500 for an ACL repair. Does it make a difference if I don't have a care card? Yes, then we can't bill MSP for your anesthesia or anything like that. You'd be looking for an additional $2,000 to $3,000. So what does the $7,500 pay for? It's the facility fee for the ACL repair. So looking back to how Medicare impacts doctors and hospitals from the very beginning of the presentation, the opt-in, opt-out, bill in one sector or bill in the other, that's not happening. And the fees are exorbitant, which is the title of the slide. Needed to point that out. The other thing is queue jumping that's happening. I'm calling for my mom. If her doctor says she needs cataract surgery, can she buy it at your clinic? Yes, we do private surgeries 1 day a month. The next one is September 25th. This call was made in end of August, by the way. But you need a consultation first. How much does it cost? The clinic has a user fee of $1,000. Then you have to pay for the lens. Could she get a consultation before September 25th? Well, if she's coming in for private surgery, we could fit her in. User fees and limiting access of patients to physicians. Just to clarify, if I got a membership in your elite program, then I wouldn't have to compete for time slots with people who haven't paid the membership fee. Because you don't book appointments for people that don't pay it and just want to use their care card, right? Yes, that's right. That's why we can keep it so the doctor can see each patient for half an hour instead of the 5 minutes you get in the public system. So doctors restricting their practice to patients who can pay, which is also against the law. So in 2008, the BC Nurses Union launched a suit on behalf of patients who were charged exorbitant fees at these for-profit clinics. In the next year, Dr. Day, who's the owner of the Campbell Surgical Centre, the probably largest and most successful for-profit clinic in BC, launches a countersuit, basically claiming that restricting the expansion of private clinics deprives patients of the charter rights, very much in line with the Chaoulli ruling. And that it's unconstitutional to not allow patients to spend their hard-earned money in a democratic society on the things they want, including healthcare. So, how many years? We're 3 years later now, 4 years since the lawsuit was filed, and after multiple attempts to block access to his billing records, finally the Medical Services Commission this year was able to access only 30 days of his data. And that's important because any for-profit institution doesn't need to be accountable to government for how much they're charging. They don't need to reveal their costs. So we can't actually look at these for-profit clinics and say, are they efficient? Are they cost-effective? What are their outcomes? And that's what we like to do, to look at the evidence around major policy change, like for-profit clinics. And we don't even have access to his data. And not only that, but he's blocking access to it. But in that 30-day period, they found almost $500,000 in extra billing, including $66,000 in double billing, meaning the patient and the government were billed for the same thing. And so he was ordered to cease these practices by the Medical Services Commission. He didn't, because he's challenging the constitutionality of the law. So he's continued openly to break the law as he awaits this constitutional challenge. So the next step is on October 18th, when the provincial government filed for an injunction from the courts to force him to stop these illegal billings and act in compliance with the law. And so that injunction will go to court on October 18th. There are some worrisome consequences that could come from that, in that the court could rule, well, he's challenged the constitutionality of it, we'll just let him continue doing what he's doing until that goes to court, which is already setting a legal precedent that we're allowing for-profit expansion of clinics. I mean, we've been allowing it by not cracking down on them for the last 10 years, but as soon as this comes to light in the legal system and in the public eye, it just becomes that much worse. And what will the penalty be if he doesn't stop? The penalty for the public system will be tremendous if this continues. So as the public and as physicians, and especially doctors from Medicare, which is fighting this as much as we possibly can, is to press for real consequences. We want the law to be enforced. We recognize that patients, the government has allowed gaps to remain in the system. And the reality is that people are now depending on these for-profit clinics to get their care. So is it the right thing for him to shut down his practice altogether and have a lot of very upset people who had already paid to skip to the front of the line and now are left without care? I'm not sure that that's the right thing, but he can certainly start billing in accordance with the law and operate as a nonprofit facility. But he's making millions of dollars a year, so he doesn't want to do that. And we need to raise the issue to the media. He's had a very powerful voice. The whole for-profit industry has a very powerful voice, certainly in the States and also in Canada. So this counter voice is generally underrepresented. Briefly, some of the evidence around for-profit institutions. So this is these next few slides are from studies that were done on the American system, looking at for-profit and non-for-profit hospitals in the US. For-profit hospitals cost 19% more. They're more expensive. You'll see this data come up similarly in the P3 presentations, but this is in terms of hospital operation as well as capital costs. How important is that 90% increase? It would be $11 billion in excess charges per year if we translated that to the Canadian system. It's a huge impact. So this is another study that looked similarly. It showed 20% higher costs, so about the same number, and also 5% more deaths, which is a tremendous amount. I think it ends up being about 4,000 more deaths annually, somewhere between 3,000 and 4,000. This study looked at for-profit versus not-for-profit hemodialysis units and found that there was a significant range of excess deaths in the for-profit sector in the States. And we know that one of the reasons why is because they are changing their dialysis filters less often. You have to cut corners somehow if you're going to make a profit, right? And so overall, for-profit hospitals are associated with 2% more deaths. I'm sorry, the $3,000 to $4,000 or 3,000 to 4,000 excess deaths per year figure translated to the Canadian context reflects 2% more deaths, not the 5% of the previous slide. So briefly, Australia in the 90s introduced a parallel system of private finance for inpatient hospital care, which ended up having to be bailed out from the government because they weren't making the profits that they thought they would. And what it ended up doing, it actually ended up increasing wait lists in the public system. And this is a really important point to remember. That's really not that well understood. I mean, if you look at the graph, basically, you can see on the left of the graph represents more private care in a community, and on the right side of the graph, more public care in the community. And the wait times dramatically and linearly decreased the more public the care was. So this is a pretty important slide because we have this sense that, well, a little bit of for-profit care in the system, a little bit of investment in for-profit sector in healthcare in Canada will just take the pressure off the public system. But that's actually not true. The first is just basic math. There are only so many doctors and nurses in the system. There's only so much of the budget in the system. And the more of that that's spent in the for-profit sector means there's less available in the public sector. Performing more unnecessary procedures in the private sector has been shown by research in the United States just in the last couple of years, that people who buy their way to the front of the line are not necessarily getting better care, they're just getting more care because they're advocating and they're stepping forward. And so you get the wealthy group who's paying their way to the front of the line, who are actually draining even more resources out of the system by getting excessively investigated. You know, you've probably heard of these executive super checkups that exist in some of these clinics where, you know, people basically get a full body MRI and every blood test that you can imagine just to get an overall status of their health. And that's real, and it drains resources from people who probably need the tests more. The other thing that happens is that for-profit sector always cherry picks. There's only some areas of healthcare that you can profit from. So like the ACL surgery on a young soccer player who doesn't need to stay overnight in the hospital is going to be less costly than a hip replacement on somebody who has diabetes and COPD and who needs a 3-night hospital stay associated or more associated with their surgery. So the for-profit sector will never touch certain areas in healthcare. And so that's how they make their profit. And the public system ends up dealing with the more complex cases. So the average patient in the public system stays longer in hospital, is more complex, and costs the system more when you skim off all of the healthy and wealthy people who get their care in the for-profit sector. I hope that makes sense. And so I think we covered that. The Canadian Medical Association has recognized all of this evidence, and they're a conservative organization, and despite Dr. Brian Day having been the president in the past, does not reflect the direction and the philosophy of the organization, which has recognized that although private health insurance can provide greater choice and access for those who can afford it, it has not been found to improve access to publicly insured services, to lower costs, or to improve quality. The other shift that's happening, a bit more under the radar, comes from a wealth of evidence in the last 20 years, a lot of it done in the UK, studying how social class and how income affects health. And the data is overwhelming and has been overwhelming for a long time. And as healthcare gets more expensive, we're starting to recognize that if we address inequities, if we start to bring everybody up to the same level, that it'll actually benefit everyone. You know, homeless patients, you can imagine, have a hard time keeping on track with their system. They don't have a calendar, they don't even have a place to live. How are they going to heal from whatever their health condition is? And that ends up causing them to cycle through the system. So, develop a housing strategy, get them housed, it will cost the health system less. And that benefits everyone. That benefits everyone. So this is just 2 slides demonstrating how powerful the evidence is, linking income and social status to health outcome. This is from the UK, showing life expectancy and disability-free life expectancy based on income. And as you can see, so the top line is life expectancy, the bottom line is disability-free life expectancy. And that both of those are directly related with a large cluster of data supporting this, directly correlated with income. This graph shows rates of poor social and emotional adjustment of children based on father's social class at birth. To the right of the graph is a lower social class, to the left is the highest social class. And you can see another direct relationship. And you can tell how social and emotional adjustment is a very complex issue. And the fact that it has such a strong relationship to income and social status is very powerful. So the Canadian Medical Association this year, they had their annual meeting in Yellowknife, and the whole meeting's subject was on inequities. And they made a commitment to addressing inequities in Canada, which is a huge shift for the organization. We were there, and my jaw was on the floor as we were talking about housing strategies. We were talking about food security. We were talking about outreach. We were talking about things that I never thought that a medical association would recognize. But we're getting to the point where we have to do it, and that's the other shift that's happening that I'm much more inspired by. But there's no worse way of addressing inequities than to introduce a two-tier system where certain people are buying their way to the front of the line and others are not. And so here's a pyramid that sort of describes what a delivery of an equitable healthcare system is. And it all heads towards the peak, which is to reduce health inequities and improve well-being for all. And I put a couple of arrows in there so that you can see how this participatory engagement, like what we're doing tonight, is part of that process. So, if I can read, it's really small. So, on the left side, the arrow on a slant, integrated delivery through greater civic participation, third and public sector partnerships. On the right, a new model of political, civic, and public sector leadership grounded in local democracy and whole system thinking. And the value base that underlies this whole vision for a better system is equality and health equity in all policies promoting fairness. So the fact that you're here tonight is starting the movement towards this, the vision of an equitable and more promising future of healthcare. So briefly, challenges ahead. So just to transition us into the conversation on P3s. The effects are substantial. So as I mentioned at the beginning of the presentations, when Medicare was implemented, doctors were able to bill the government for the services they were providing, but they kept their clinical autonomy in that they could decide how and where to run their practices. Once you introduce for-profit sector, what's going to happen to that clinical autonomy? What's going to happen in a hospital if instead of having a transitional care unit and a home care team down the hall, you've got a cosmetic surgery and private MRI suite? How is that going to change the way doctors decide to practice and the kind of services that are available to patients? In my view, the things that I actually need for my patients won't be there, and the kind of things that make the hospital money will. So as we can see with the sort of trend toward privatization so far, is that doctors are now opting in and opting out of Medicare. A lot of doctors do a private practice on the side and also bill the public system. And that in the past has been illegal, but it's been increasing. So how's that going to change? You know, I just envision doctors shifting their care towards more for-profit care. The other thing is, you know, working in an environment where you feel like people are on your team, where you run into a snag at work, in the hospital, and you have somebody to talk to about it because you're concerned about its effect on your patient. But if the hospital is accountable to their shareholders and to their owners and to the profit margin, and not to the people who work in the hospital and not to the patients in the hospital, it changes the dynamic completely. And instead of improvements of care, we get the energy directed towards efficiency and cost saving, and that creates a toxic environment, I think, both for staff and for patients. And then I just wonder what's going to happen if you privatize the cleaners. What's going to happen to hospital-acquired infection rates? If to make a profit you need to cut corners, where are those corners going to be cut? The other thing is mental health care. Can you really make a profit from a hospital if you build, say, in the emergency department, a quiet space, a place where the mental health patients can come in and not be stifled in a corner in a loud, noisy environment where you can actually give them the quiet space that they need? I can't imagine that being built into a for-profit system. How is that going to make people money to give people the space that they need? And that, for me, is an issue of respect and proper care. And I just don't see that playing out in for-profit settings. What are the effects on patient? As I mentioned, cost-centered, not patient-centered care. Less team-based and collaborative care. If you're trimming down your staff options, and if things are being centralized, there's less opportunity to work together as a team. As I said, you've got the divisions built into the hospital. And I think the best patient care is when you have the family at the table, the patient's views are represented, and everyone on the team is deciding what's best for the patient. Presumably less spectrum of services offered, perhaps cosmetic dentistry instead of something more needed. And then inevitable cutting of corners. The quality of the actual physical facility. In the UK, they found that roofs were collapsing in patients' rooms because of corners that were cut during construction. Quality of food is something that I probably don't even need to mention. Extra services. How many things can you define as a supplementary or excess service that the hospitals then don't have to take care of and that you might have to pay for out of pocket? And skeleton staffing, where patients just aren't getting the full support that they need. And then the other question I wonder is, what about patients that don't make the hospital a profit? What about those who have addictions? What about those who don't have supports at home? Those who don't speak English? and who need those extra supports. Can a hospital really profit from those patients? And if so, will they just be discriminatorily discharged from the hospital early, or perhaps not even admitted? I'm not sure. So we need to look at a different pathway. We need to recognize the rhetoric and the evidence that is true, rather than the evidence that is inflated and misrepresented, and return to our values, and return to the principles that founded Medicare in the first place. Tommy Douglas, when we began to plan Medicare, we pointed out that it would be in 2 phases. The first phase would be to remove the financial barrier, largely through hospital care. The second phase would be to reorganize and revamp the delivery system. And of course, that's the big item. It's the big thing we haven't done yet. So think about this, the next stage of Medicare. If we, for example, implement a national pharmaceutical strategy, we will save $10 billion annually, which will add a lot more money to the pot that we can use to develop, in my view, a national home care strategy would be fabulous. And we've got all the ideas on the table. We know exactly what we need to do. We need to centralize referral service to specialists, so doctors aren't on the phone double booking patients at different specialists, seeing who they can get in faster with. Interprofessional care, so actually create more team-based care. Prevention, which is not something you'll ever be able to profit from. Better patient-centered chronic disease management, and improved care in the patient's home. And we need to get this electronic health records thing on the go, not in separate little pockets, but something that's integrated provincially and ideally nationally. So, our role here, my role here with you. So we'll talk about P3s in the next presentation, but I'm labeling it as the successful P3 fight, because the Citizens for Quality Healthcare group has impressed me to no end in the 2 days that I've been here. And I have no doubt that if you raise your voices, that the P3 hospital will not go through, so please continue to do so. And after that successful fight, let's begin a conversation about how to improve the health system as a whole. Because it's one thing to fight the P3 hospital, it's another thing to bring ideas to the table that will actually create a more sustainable and cost-effective system. So please lend your voices, and please pay attention to how the Brian Day case pans out, because that will require a united voice from across the province as well. Another thing, demand a 2014 health accord. And call the federal government back to the table. You know, the Council of Federation that has been formed between the provinces, it hasn't gotten anything off the ground yet. Canadian Doctors for Medicare has provided them with evidence and recommendations in keeping with the goals they have set, and they haven't made any progress on any of them. And it's been almost a year. The federal government is there for a reason. They were in a central role in the foundation of Medicare, and they need to be there still now. And let's take the opportunity for a 2014 accord to set goals for the system. And let's build a pyramid towards the healthcare system that we want, rather than letting it suffer political term to political term. And the federal government won't talk about healthcare, so make them talk about it. You know, they'll decimate the environment and be clear about that in the media, but they make sneaky announcements before Christmas, hidden underneath financial jargon, that don't actually say that we're not going to renew the health accord and we're not going to enforce the Canada Health Act. If they were to say that directly to us as Canadians, we would not stand for it. We need to hear their viewpoints and hold them accountable to it. And then be aware that the slow erosion is happening, the creeping normalcy that I mentioned, that as you leave gaps, the gaps will be filled by the for-profit sector, which is so highly evolved in the US. And keep in mind, as soon as the floodgates open and the legal precedent is set for for-profit care in Canada, under NAFTA, we have to allow them. And if the government wants to crack down later on, they could sue us because we're legally obliged to then provide health care as a freely traded good. That's a very dangerous path. So, Doctors for Medicare, very briefly, we are a physician-led organization, but most of our membership are not physicians. So go to our website, we've got a lot of resource material there. And if you'd like to become a member, I'm not sure actually how much the membership fee is, but basically we take as much as you're willing to offer, even if it's just $5 to help cover some costs. And then you get monthly e-rounds where you basically get a policy update on something important happening in this healthcare discussion. And yeah, and you can bring me to things like this. So thank you so much for your attention and for your continued engagement.
Thank you. Next, please. Elliott Buckley.
Thanks very much. Well, thanks very much, all of you, for coming out tonight. It's great to see so many people. And I feel quite honored, actually, to be here. I was following what's been going on in the last 6 years with democratic activism around the province, and I've certainly seen a lot of it on the North Island. And I spend so much of my time in my little research cave in my office. It's rare that I get a chance to get out and actually interact with people who are union members and community activists and Council of Canadians, all this kind of stuff. And last night, I took a long time to get to sleep after being in Campbell River and being really inspired by the people there last night. So tonight I want to talk about P3s, which are a horribly complicated economic, massive voodoo economics and horrible, horrible things. It's going to take me about 3.5 hours to really fully give you a sense of things. And if you can stomach that, you can sort of hang around afterwards and I'll give you the private lesson. But this is the short version, and I've been really merciful, I think. I've included just one graph out of all the spreadsheets I could have stuck in. But I want to talk a little bit about P3 definitions and the difference, the whole spectrum of privatization, because it's not black and white. There are advantages to P3s, that's what we hear, and most of it is spin because I've got a counter argument for each one of them. And I want to spend a bit of time talking about the disadvantages, and I'm sure all of you know at least a handful of disadvantages, but I'm going to give you like 13 tonight. Also want to talk about the UK legacy, our great colonial power that created this Canada kind of thing. They also are the ones who sent us P3, so we can thank them for that. And I want to end with how to oppose the P3 model. And I already know that you know how to oppose the P3 model. We've already got one of the big wins already, but I want to talk about some systemic flaws in the P3 model that you can take advantage of and think about as you frame your next campaign for these hospitals. So the first thing I want to talk about is C2P3, which is not a Star Wars droid, but it's the Canadian Council for Public-Private Partnerships. And they're the lobby group, the industry organization for the corporations that form these massive consortiums to bid on these projects. And they define a P3 as a cooperative venture. I like that word cooperative, it makes me feel warm inside. A cooperative venture between public and private sectors built on the expertise of each partner that best meets clearly defined public needs through the appropriate allocation of resources, risks, and rewards. It's a beautiful definition and it makes me feel very happy. And what it suggests is that, wow, tax cuts are great, government, there's so much waste, I like my tax cuts, but we still want to do things. What if the private corporations coughed up some cash and we do things as a partnership? That feels really good to me, and that's what they want everybody to think and feel about this. And Partnerships BC was created over the last 10 years in the Liberal regime to promote public-private partnerships, but essentially their core goal is to objectively evaluate whether a P3 would be good value for money compared to building something with public dollars. And so their goal is to be neutral and objective, and that's not so much the case. But here's how they define a P3. A public-private partnership is a partnership arrangement in the form of a long-term performance-based contract between the public sector and the private sector to deliver public infrastructure for citizens. And I want to talk about infrastructure because it's a real geek term. And it generally, physical infrastructure refers to schools, hospitals, bridges. I like your bridge, by the way, it's coming along quite nicely. Bridges, schools, hospitals, buildings and things that are large, like highways and tunnels and things like that. They're really expensive and they're public goods. They're good for all of us. Water treatment plants and stuff like that. And then there's social infrastructure, things like the healthcare system, not the hospitals, but the people. And lots of you tonight are in healthcare. Mental health, education, community services, the YMCA is a nonprofit that supports the social infrastructure of the country. So apparently we have somewhere between $130 and $180 billion infrastructure deficit in this country. And that's just physical. So all the bridges and roads and sewer systems that are falling apart, we need to replace them. And I just remember from Vanessa's slides in terms of the corporate tax revenue we've been foregoing for the last 15 years since Paul Martin became finance minister to pretty much cover the infrastructure deficit going forward the next 10 years. But that time's gone, so we can't go back. But I want to stress long term. And you know what long term means. How long is the P3 threat that you guys are dealing with here? 30 years. That's a long time. What's this? Don't look at the bottom. Here, I'm covering the bottom. Anyone know what that is? Don't read the bottom. If you can read the bottom, don't say it. Come on, you should be able to recognize this. Mount Albert Everest. Now, is this inside or outside Strathcona Park? I can't remember. Inside. Okay. So next month, Thanksgiving Day weekend, is the 22-year anniversary from when I've climbed this mountain. How many of you have been up to the top? Okay, it's not Everest, right? You can just walk up. It's a hill. It's kind of loose rock, so it's kind of tricky, but I made it up to the top. It was really great. First mountain I ever climbed. It was really wonderful. But that, you know, thinking about coming here, and I haven't been to this part of the island in a long time, not 22 years, but I thought 22 years is a long time. And then I thought about 30 years. And 30 years is 8 more than 22. So I'm just getting a long-term picture in my mind, and I know a lot's happened in my life in the last 22 years. And I'm going to come back to the mountain at the end again. The P3 spectrum, this black and white notion of public and private, it's a spectrum. At the very bottom, we have something called design build. And this is from C2P3. This is how they describe what a P3 looks like. So design build is in black, and there's a big line across it, which basically means they don't have access to design build projects. And in the old days, in the good old days before the corporations were jumping into public infrastructure, a school board needs a new school. So they put out a bid, and a bunch of architects get together and they bid on designing a new school. And so one is picked, and then they go to the builders, and who'd like to build it, and they build it, and then it's done, and then there's a ribbon, and somebody cuts the ribbon, and then they hand over the keys to the school board. That's a design build. Someone designs it, someone builds it. We don't have architects and construction workers on staff in school boards. We just hire somebody to do it, and they build it something, kind of like a house. And then everything up above is P3able. This is where the corporations want to get into our sector. So there's operate and maintain. That's the first red one at the bottom. And then there's build and finance, because financing is great. Why raise taxes when corporations can cough up the money? But whenever a corporation invests money, what do they want in return? Profit. And they're gonna get it. Then there's DBFM, design, build, finance, and maintain. And then there's DBFMO, design, build, finance, maintain, and operate, because you know how good corporations are at operating hospitals. We've seen that for a long time. And then there's concession, which is like a government can come in, Canadian mining companies that have concessions, and they go and mine for something in other countries, and they pay a royalty to the government. And then there's just outright privatization. Who wants it? Hospitals for sale, here they go. So that's the kind of spectrum we're talking about, and most of the P3s we're looking at are in the lower end of the red boxes there. And then the City of Edmonton, which itself actually created a company called EPCOR, which does lots of interesting for-profit infrastructure work. They have their own sense of P3 continuum, same kind of boxes, same kind of words, and they're city-owned and operated on the bottom, which is very public. Then there's contracting out, that's a phrase we know all too well in BC. Then there's the design build, and all of those are considered to be public, though honestly contracting out, I kind of disagree with their slide there. Then there's design, build, operate, and then DBFO, and then the top one, which is great. Design, build, finance, own, operate, transfer, which basically says every kind of P3 that we see, and then in 30 years they give it back to us. And if I have a house and I sell it to you, and then I rent it back from you for 30 years, who's ahead? Me or you? No, it's not me. I mean, the asset's good. And honestly, I don't really want a hospital come back into the public system after 30 years after someone else has been working on it, because I'm not sure they're going to be, well, will they cut corners? I think they might. So there's advantages for P3. This is the spin that we hear all the time. First of all, cost overrun risk. If you're going to build something, holy cow, it always costs more when you're done. There's that new convention center in Vancouver, which cost $800 gazillion more than they thought. They put a new roof on the stadium, BC Place Stadium, which cost more than the stadium in the first place, but that was $1983. But things get more expensive when there's a cost overrun. So instead of the government being on the hook for that, well, let's just force corporations to be efficient. And if they don't plan well, they lose their profit. They have to eat it. And so in order to pass on that risk, we are no longer on the hook for that, because it's the partnership and the private corporation deals with that. But the risk is always built in. What kind of corporation could go to sleep at night if they haven't negotiated properly with the government so that if there is some kind of cost overrun, they're going to get reimbursed for it? And they do, because their goal is a 9 to 15% return on their investment. And 9% is huge. What's your savings account making you right now? Over or under 9%? I think it's a little lower. Rigorous competitive selection process. That's a phrase that I just have to put in quotes because it's too good to be true. This is Partnerships BC, because they actually say, well, the marketplace has this competitive element, and so all these corporations will race here to bid on things. And the RFQ for your hospital, how many corporations in the world really are all that able to build these hospitals and these bridges and tunnels and roads and things like that? We're not talking about thousands, there's like 6, 7. And they build a consortium, and sometimes there's 1 or 2 consortiums pulling together to put a bid in. So there really aren't that many competitors. And actually, in the last few weeks, we've had a surprising new ally in this. The BC, I can't remember the name of them, the Independent Business Group, have come out actually accusing Partnerships BC of conflict of interest, because there's all these companies that used to build all our schools and hospitals and roads in BC, and they're kind of shut out because they're not global corporations like these massive construction firms that fly all over the country, all over the planet building things. So our local industry is being shut out, which is really unfair. But really, actually, their big criticism of Partnerships BC is that instead of neutrally evaluating options from the public option or the P3 option, they've had a new role added onto them in recent years, which is to manage the projects themselves, which is an inherent conflict of interest. So there's some really interesting writing about that in the last couple of weeks. I'm like, thank you, independent businesses of BC, for supporting this idea that we should be building our own things. How many more ferries do you want to have built in Germany? Any? Like, I'm done with that. So public sector focus on core service delivery. And anytime you hear the word core, you should perk up your ears and just let out a little chortle and a scream. Because whenever anyone says core, what's the opposite of core? Peripheral, non-core. Something's really important, and then there's just the other stuff. And I'm going to get to this core, non-core distinction later on, because it's every time you hear it, they're trying to divide us. They're trying to separate, erode our solidarity, and erode our team focus. And I heard Vanessa say the word team 3 times, and I'm going to say it a lot as well. Private money cures the infrastructure deficit. Well, no, it doesn't, because what it does is it creates a justification for the right-wing governments to continue cutting taxes, because we don't have to put aside a whole bunch of money or put out new bond issues for these really expensive infrastructure projects. And in the end, we always pay. You know, we're either going to pay now, or I can rent a house for the next 30 years, and what do I have to show for it? No house and way more money than I would have spent on buying something, unless you live in Vancouver. Then there's operational savings. They say, well, we'll save money running this kind of stuff, but we haven't seen that. We've seen contract flipping, we've seen consortiums come in and sell their interests, and they say, hey, look, I've got a 30-year guaranteed deal with this government that will always pay, because they could just raise taxes in order to pay for this contract. Who wants to buy me out? And look, people are lining up all over the place to buy them out. And then there's contract flipping for the contracted out services, and which creates monstrous destabilization within healthcare professionals. And nobody needs that, certainly not patients. So instability is the word of the day. So what are the disadvantages? Well, here's the first slide, and here's a sneak peek at the second. There's 11, sorry, not 13. There's democracy problems. Anyone spotted that yet? Governments are lying and hiding information. It's not new, but it's current. Freedom of information requests, holy cow, it's hard to get information, and it's hard to get the financial statements, and it's hard to get the beautiful little spreadsheets where Partnerships BC compares what's the cost of this thing if we borrow money publicly through the government, and what's the cost from a P3, and can we compare them? And one of them's going to come out ahead all the time. The voodoo that goes into those spreadsheets will blow your mind, because we've seen little bits of some of them, but mostly it's hidden. All the way up to the fact that we've put in FOI requests, and we've had responses come back saying, this is cabinet secret, nobody can, there's like all these reasons they can redact information, and they've panicked so much. Like, okay, we'll call it a cabinet secret now, so we can't let this number out. So we're not seeing a lot of transparency. The value for money voodoo, well, I just talked about that. It deals with also the present value and future value of money. If you ever took a finance or economics course, you're trying to figure out, let's see, if you win the lottery, do I want it a lump sum or $25,000 a year, and which is going to be worth more? And you could do math and sort of guess what the interest rate's going to be for the next 20 to 30 years, and project something forward, and then you bring it back, and you figure out numbers that you can compare. And it's all based on the fact that somebody in Partnerships BC has decided they think they know what the interest rate's going to be for the next 30 years. I don't think so. The interest rates have done crazy things since 9/11, so I don't know. Risk transfer with consortium collapse. Consortiums are made up of companies, and companies can come and go. They can close down on any given day if it's more profitable, and they could just walk away. And who's going to sue them? They close shop. They're bankrupt. You can't do anything to them now, and they walk away. And that's a real fear, but actually it's happened. It's not just some voodoo myth that I'm going to toss out. The Metro is a P3 in London, And not only did the City of London have way too few people, it had like 6 people or something monitoring the corporation to be able to send their financial statements in, do regular reporting. They needed like 8,000 people to monitor this consortium because they were slippery. And in the end, the consortium just found so difficult to maintain this, they just closed up and walked away. And the City of London was left holding the entire bag, even though they had all this commitment from this future money and stuff. It was a disaster. Then there was Hamilton, the sewage system. Don't privatize sewage, and the CRD folks know all about that. The contract was flipped, the owners changed all over the place. At one point there was a company called Enron that had a subsidiary that owned the contract. There were sewage spills, and eventually it collapsed, and it went back to the City of Hamilton. They're like, thanks a lot. So they got stuck with it all. Financing instability. Corporations can be vulnerable, and sometimes the biggest companies in the world are too big to fail, except they do. And we've seen that in the last 4 years since the most recent crash. There's also delays. How long does it take to negotiate a P3 contract? I don't know, a weekend on the golf course, or 3 to 10 years? What's your guess? The SkyTrain system in Vancouver, the first one was built for Expo in 1985-86. The Millennium Line built late 90s. It took 3 years to plan the Millennium Line. That was publicly done. And then 8 years for the Canada Line that goes to the airport. Well, that's kind of long, it's a shorter line, but it took longer. And then it's been so far on the clock 10 years, and they still haven't got the Evergreen Line going to the northeast suburbs. 10 years, that's a very long time, and the lawyers are making so much money. So there's delayed service, and then of course as time goes by, costs go up. And the price of steel, anyone tracking the price of steel in the last 10 years? It's gone through the roof. Confused accountability and communications. If you have a P3 in a hospital, you have a health authority, you have publicly employed staff, you have privately employed staff, and the team breaks down. So if you have a doctor, a nurse, and a housekeeping professional in a room, in an emergency room, and there's been a patient in and there's a bit of a mess that needs to be cleaned up. In the old days, they used to sort of look at the housekeeping professional and say, how long is this going to take to get the room cleaned up? And say 6.5 minutes, and they get the job done and they move on. Now what you have to do is the nurse has to phone a centralized dispatch call center in order to request a room to be cleaned and how much cleaning needs and all this kind of stuff. And then somebody who's going to get paged or somehow, I don't know how they do it, from some centralized system to come in. Even though there's 3 people standing there, it doesn't work like that anymore. So, and this is just a simple example of the monstrous complexity that comes when people report to different people and they're not working as a team anymore. Difficulty monitoring corporate partners. Yeah, that costs a lot of extra money, and the City of London found that out, that they didn't budget in for how much they'd have to pay people to be watchdogs for the corporations they hired. Increased costs are always passed on. New fees showing up. There's a toll going on the Portman Bridge any second now, and that fee can go on forever. The Coquihalla, remember the toll booth on the Coquihalla? On a Friday morning at the Union of BC Municipalities a few years ago, which is tomorrow morning when the Premier speaks, Campbell announced that, we've paid for the Coquihalla, we're taking the toll booths down as we speak. And then there's these shots of like them knocking down the toll booths, and everyone cheered because that's our highway. But what if it's not our highway? What if it's been paid for over and over and the tolls keep going up? That's the user fee for a road. But a hospital, I don't like user fees in medical care. Cuts to subcontractors and staffing, these costs are passed on all through. If you're going to increase your profit, you have to cut corners somewhere. It also handicaps the local economy, so the conflict of interest I mentioned with Partnerships BC, and all of our expertise about building, isn't it in our best interest to make sure that provincially based corporations can do a better job in the long run of having skilled workers who know how to design schools and bridges and hospitals? But if you shut them out of it, it's like, where's that brain drain going? Where's that knowledge and talent? It's disappearing. And we aren't self-sufficient in building our own infrastructure, and that's a weakness. Less control over policies and service development. Democratically elected leaders and health authorities, like in the old days and maybe in the future, I think democracy is a good thing. I think people should be accountable at the ballot box for decisions they make, good or bad. And if you let a corporation make a decision about how much cleaning happens in Burnaby Hospital over a period of 18 months or something, I don't think that's a good idea, because their interest is not maximizing clean hospitals, it's maximizing profit and shareholder wealth. And finally, the cost of borrowing is higher with corporations. What kind of loan rate can you get on a car loan or something like that if you have a good credit rating? It's probably pretty good. And what if it's your 19-year-old son who's working at McDonald's? Is his interest rate going to be a little higher or a little lower? It's going to be a little higher. When it comes to governments and corporations, the government can take a loan, can float a bond, and its interest rate is really low because there's no risk. Because in the end, they're going to pay off the bond, and if things get tight, they just increase taxes, because they can do that. Corporations, they can't do that. They have to borrow money slightly higher. And enormous corporations have a really good interest rate, but it's never as good as a government like BC with a AAA credit rating, with really low rates. So what this chart shows you is the difference between what a government could borrow money for and a private corporation. What year do you think that first spike came in? 2008. Anyone know what happened in 2008? There was a bit of a crash, right? So all of a sudden the interest rates went through the roof. And actually the first spike, the first spike on the left, the halfway up one, that's 2007. I can't even remember what happened like 8 months before the crash. But the tallest one, that's the summer of 2008. So why would you argue that private corporations can borrow money more cheaply than governments? Because they can't. And we actually found that with the Courtenay Bridge, because it was going to be a P3, and there were lots of complications. Also the Golden Ears Bridge, way out in the Fraser Valley. That one, there was a nervous weekend when there was an Irish bank that almost went under, and its parent bank in Germany got a bailout from the German government, maybe, and there was like 48 hours of real tension. And the BC finance minister, I think it was Colin Hanson at the time, was at a meeting in Toronto, and everyone's asking him, is your bridge going under? And he couldn't answer. He was like, oh, I'm not going to comment on that, blah, blah, blah. And all he's doing, he was waiting to see if the German bank got bailed out by the German government, so the Irish subsidiary in the consortium that's building the Golden Ears Bridge doesn't go belly up, and the BC government has to bail the whole thing out. It was a tough weekend for Colin Hanson. He got a few gray hairs, I think. So honestly, I don't want corporations lending me money at a higher rate than I could borrow it as a government. So going to the UK, hello UK. John Loxley, a spectacularly brilliant professor at the University of Manitoba, did some studies on the P3s in the UK. He did this study 11 years ago, okay? So no one can say they didn't know that this was happening, what was gonna happen. And he studied these things and he found a pattern. Governments exaggerate the capital and operating savings. They make stuff up. They say we're gonna save more money than we will. There's this illusion of risk transfer because it always rests with the public body. No evidence of improved service levels. Who's been talking about that actually in BC in the last 10 years? We're going to P3 your hospitals and everyone's going to get healthier faster. They're never arguing that because they can't promise that at all. Foreign ownership risk. I do not want some of the companies in the consortiums that have built things in BC to be in charge of what goes on in BC because they're not even Canadian companies. We don't have access to them. And all their profits get sucked overseas and we never see it. And the decision-making accountability is in another country. So, there's a real disconnect there. User fees can lead to unlimited profits, and the word unlimited is unlimited. Asset leaseback is expensive and retains public liability. Why would I sell you my house and then rent it back from you until I die? That's just foolish. Public sector administrative brain drain. All the talent we had in the public infrastructure, the human resources infrastructure of the BC government, who used to build hotels, hospitals, roads, bridges, schools, all those kinds of things. Do you know how much money they make if they take a job with the consortiums? Quite a bit more. And the good ones leave because they're really good. And the ones who aren't so good, they get to negotiate on behalf of the government. Then this great quote from Loxley: wages, benefits, and pension funds can be sacrificed in a P3 agreement over which they have no control. Workloads are often increased significantly, placing workers under tremendous pressure to meet service guarantees. Anyone heard of workload increase in BC in the last 10 years? I have. Also, Alison Pollock, who's one of our patron saints of spreadsheet healthcare statistics from London University, she did a study on P3s as well 11 years ago. She said a few conclusions. Accompanying P3s are major reductions in quality and access, growing wait lists, and a two-tier system. Those who can afford to pay are paying privately for care. There's a 30% reduction in beds and a 25% reduction in care. And we've known this since 2001. But the rhetoric we've been hearing is on time and on budget. No, they're not on time. The delays are insane. And in their contracts, they build in triggers and conditions for what happens when there's a delay. So they could delay for 100 years and it's not a delay because it's still part of the target date of the contract. And it's not so much on budget, and you'll see why in a minute. So all this mythology, and if you say on time and on budget enough, and Gordon Campbell must have said it, 5 million times in the last 8 years, people start believing it, and they don't question it, and they look at numbers and they go, well, no, he said it's on time and on budget, even though those numbers say it's not. Which moves me into this phrase, faith-based economic policy. If you believe in me, and believe in on time and on budget, and believe in trickle-down economics, trust me, it works, okay? It works. and then you move on. But evidence-based policy formation is based on evidence. And if there are facts saying that these are the trends and these are the massive profits these corporations are making, well, don't the numbers speak? I think they kind of should. So what have we seen in BC? Here are the projects on Partnerships BC's website. The first column shows you what our future is looking like. 3 announced projects in health and 1 in transportation, K-12 energy, smattering here and there. Under construction now, more health, transportation, and a few others. And what have been completed so far? 14 of the 17 that have been completed so far are in health and transportation. Big profit margins there. And so then there's the Nanaimo Bingo Gate, Commonwealth Bingo Gate scandal. Do you remember that one from the 90s? There was some sort of really huge scandal with the NDP in the 90s, and there was this guy, this magician called Ron Parks. He's a forensic accountant. Best one in the province, as far as I can see. And he blew the whole thing wide open because he's an accountant and he can look in and figure things out. So QB contracted Ron and Roseanne Terhart to take a look at the documents we got on 4 P3 projects over the last several years. These are contract and a little bit of the financial information we were able to squeeze out. And 2 of those projects were healthcare projects, the Diamond Centre in Vancouver and the Abbotsford Hospital. Diamond Centre, $203 million. The public sector comparator was $89 million. Okay. Partnerships BC built a spreadsheet that was so spectacular that they made $203 million look cheaper than $89 million. So they're not on time, they're not on budget, and they cost more. Okay, because 89 and 203 are different numbers. Trust the evidence. Abbotsford Hospital, 355 million, not 211. That's like 50%, more than 50% higher. And they also found a few conclusions about how the P3s came into being. And they found that the process for assessing P3s is biased, obviously. And there was a lack of public accountability and transparency, if you care about that kind of thing, because democracy might matter. So how do you oppose the P3 model? Well, there's some immediate things you can do right off the bat. And the first one is team. Embrace teams. Anytime you try to increase the effectiveness of teams in healthcare delivery, the P3 is an impediment. It's a massive, it's not even a roadblock, it's a brick wall. It gets in the way of teams all the time, and it splits us all up. So whenever you hear core as well, think about support. Core is good, it's special. Doctors, nurses, care aides, everyone else can be privatized. Everybody. And what about the labs? What about the pharmacy? Housekeeping? Because housekeeping, as a BC cabinet minister once called it several years ago, is basically the same thing as what? Cleaning hotel rooms. Okay? Except people die massively when you don't clean hospitals properly, and we've seen this. My dad was in Surrey Memorial 2 weeks ago getting half his colon yanked out, and I'm sitting there for the 5 days he was in, flipping a coin every day, like, is it 50-50 chance of him getting an infection and dying? I'm just flipping these coins, like, I don't know what this means, and heads, lives, tails, dies, I don't know. And he got out, and he's fine, it's been, a week out, it was okay. I'm like, great, I'm very happy. Burnaby Hospital had that huge letter from the doctors they were writing. It's a real concern. Support isn't support. It isn't just light bulbs and elevators. It's something that's real, and these are healthcare professionals we're talking about. Also hard and soft. Soft is like, oh, soft, I don't know. Do we have 1-ply or 2-ply toilet paper? I don't know. One's hard, one's soft. Hard are the really key things, and soft, not so much a big deal. So beware of those words coming up, and I'll talk about soft in a minute. Require openness and transparency in business plans. What is there to hide? If there's a public dollar, why can't we see where the dollar goes? How hard is that? It's a political will to do that. And I'll tell you something that happened this morning. The UBCM, Union of BC Municipalities, is meeting in Victoria this week. And on Friday morning, the Leader of the Opposition speaks. That's Thursday morning. And on the Friday morning, it's the Premier. Adrian Dix got up this morning and said lots of things. I'm still trying to figure out what the platform is. But one thing he said this morning was, hey, P3s, maybe we should leave it up to the municipalities to decide whether you want a P3. And I'm thinking, oh, that's an interesting statement, which is different from the government mandate right now that says everything's a P3 unless, it just doesn't work financially. So he said that, and of course his audience is who, right? Local councillors and municipal and regional councillors. So they loved hearing that. But that's not even remotely close to a full policy formation. What that starts off saying is, hey, the door's open. And what does this have to do with you? Well, if you want to go knock on his door, he just opened it for you. Your foot can already go in, and that's the start. And in the end, what's the demand? Well, no P3s. That's it. It's 2 words, no P3s. And he's saying, well, let municipalities look at it and then they can investigate it. And I'm kind of thinking, well, that's just the first thing he's going to say. And maybe later on, after he gets elected or something, he'll roll out with like, you know what, we're going to put a moratorium on all the P3s just to look at the value for money, and we'll publish the Partnerships BC secret spreadsheets on the website. And all of you can look at it too, and we'll figure out whether they've been lying to us all the time. And then maybe we'll stop. That's kind of what I'm hoping for. But how's he going to do that? I can sit here and wish and write him an email, but these are politicians. And you know how to move a politician, right? I mean, you did it several years ago. And he's opened the door. He's just begging for you to come in and make the case so that he can't possibly say, no, well, all these people have pressured me and we have to go this way. So this is day one for this, which is pretty exciting. So read about that and say, well, that's a good start on P3s. What else are you going to say about it? And then you say, this is what you should say about it. Keeping workers in-house, that's a big deal. Is housekeeping going to be in-house or not in-house with these new P3 hospitals you're going to get? You know, you hear both things, but you know what it's going to be. It's going to be contracted out, unless you stop them. Longer term, FOI, freedom of information access to all the partners. You know, a private corporation, they're private. We can't see what their books look like because they're private. They deserve their privacy, right? But they're going to get paid 30 years of public dollars. I want to see their books. They're already turning over their books to the health authorities based on whatever the contracts require them to do, but the health authorities can't release that through FOIs because of privacy concerns. I'm like, forget it. It's my money. I want to see where it's going. And I want to see if you're making 9% or 15%, and how much of that money is getting sucked to your corporate head office in the Cayman Islands or in some other country. This is my money. I don't want a dime of it going to the profit of a corporation here or somewhere else when that dime could go into helping people get better. That's what public health care means. And how about this one? Pension funds. Why don't we invest our pension funds in BC government bonds that raise money to build ice rinks and bridges and hospitals and schools? Because we've got the money, we know what the return's going to be. We trust the government because they manage our pension fund anyway, the public ones. It's natural, but it's not even on the table anymore. And then buy out the contracts. 30-year contract going out. At some point, depending on what happens with interest rates, we can do the math and figure out, you know what? If we cut you a check for $800 million, will you go away and give us our hospital back? And they might go, yeah, how about 855? Okay then. And so BC floats a bond, cuts them a big check, they go away, we get 27 of our years back. Because somewhere the equation's going to work. It might not be now, but sometime in the future. Because they can't predict interest rates. So fixing the language too. So I talked about hard and soft, core and support. And so there's this article that showed up in the Comox Valley Record recently in the last few days called Privatization at New Comox Valley Hospital, One Topic for Town Hall Meeting. That's this. Welcome to the Town Hall Meeting. Here's a quote from somebody in VHA. The contract would likely be for 30 years and some soft services could be chosen company's responsibility. So they're not telling you right off the bat it's going out, but they are. They're just going to ease you into it so you can sort of, well, you know, we still haven't decided, we'll wait for the RFP, blah, blah, blah. And these are soft services. And once I read that word soft, it's like, oh, they think you're stupid. They think soft isn't that big a deal. It's like juniper trees versus lawns. I don't care. One ply toilet paper or two, that's soft. But it's not soft, because you know what soft is, right? And especially at North Island, it's housekeeping right off the bat. And then this other quote, the private company would need to meet specific standards, because we're going to hold these corporations accountable, let me tell you, by this contract, such as frequency of elevator breakdowns or how quickly light bulbs must be replaced. And if it doesn't meet those standards, it would be docked payments, as would be set out in the contract, because that's what I'm talking about when I say soft services. But he's not. He's talking about housekeeping. And you know what happened at Burnaby Hospital, you know what's happened all around the province when cleaning standards go down, people die. We've seen this. And I'm flipping coins wondering whether my dad's going to die from a reasonably simple colon operation. And it's all about the housekeeping. It's all about infections. So I go back to time again. And 22 years is a long time. And in 8 years, my kids will be teenagers, and wouldn't it be nice to bring them up Mount Edward, and they can say they've climbed a mountain, even though you don't need ropes and stuff. It's a huge accomplishment. And if that happens in 8 years, that's what I see as a 30-year span of time. But if I look at your hospitals, and I start today, and no one's going to break ground for a while anyway, regardless of how they're built. If I move 30 years ahead, my kids will be almost as old as I am right now. And this government will be committing their future earnings and taking money out of their kids' soccer fees in order to pay for these hospitals right now. And I think that's where we're responsible. And you know what 30 years is all about. But being here and remembering that mountain, this really brings it home to me. And The good thing about this mountain is this mountain's been here a long time. It's pretty resilient. It's made of rock. It's not going anywhere anytime soon. And that's what I've been seeing about this whole community for the last 6-7 years, watching you guys fight back against this horribly anti-democratic government. And so here's a few links to some really great reports and some things that back up some of the things I've said. And if you've signed up your email list on the list here tonight, I'm going to send a copy of this PowerPoint and Vanessa's as well out to everybody on the list so you can get a sense of it. And then once you get that, you get my email address. And if you go, I don't understand slide 12, tell me about that. I'm there for you, because the more knowledge you have in order to move forward on your fight, to bash this door open and make sure this thing doesn't come back to you a second time, like a zombie, this zombie image of your P3 again. The more empowered you are, the better chance you have of making this a slam dunk when this election comes up. And you know there's an election next spring, but there's also another one in 2 years, your local and regional district elections. These people will be terrified of you if you let them know that they will lose their job if they make the wrong decision on this one. Then they should be. This is democracy. They should be happy with you, but you know, you should let them know, like, you can be friendly, but you'll fire them if they don't make the right choice on this one.
Thank you, Stephen. Next, I'd like to welcome Barb Biley.
So I'm going to try not to repeat what Stephen said and talk specifically about the situation on the North Island. So as you probably all know, on April the 26th, the Premier announced that thanks to the hard work of Don McRae, it had been decided that we would have 2 new hospitals on the North Island. And she didn't mention anything about the finance or the methodology of these hospitals, but it became apparent very quickly on the website and through questions that they were planned to be public-private partnerships. As Stevens explained, public-private partnership is a method of privatization. It's on the continuum of privatization. Now, this has upset VHA, that we've noticed this. And Grant Hollett, who was the interim project manager, wrote an article which was published in the North Island, in the Courier Islander in Campbell River. And in that, he said a number of things which were quite interesting and false. But one of them was that no one should worry. This is not privatization. No one should worry that, I'll quote you, we must be very clear that the Vancouver Island Health Authority will retain responsibility for all healthcare delivery at the new hospitals. Healthcare services will continue to be publicly funded in accordance with the Canada Health Act. VHA will own the land and the buildings, and staff related to the delivery of clinical services will continue to be employees of VHA. That's an extremely important phrase. Staff related to the delivery of clinical services. They are now redefining it on a recent document on their website. They talk about healthcare services. According to the legislation, Bill 29 and one of the bills that followed, there is actually a definition in law in British Columbia of what clinical services are. And the people who are captured by the term clinical services are registered nurses, perfusionists, pharmacists, and cardiopulmonary technicians. We won't have perfusionists. They operate the heart-lung machines in operating rooms. We won't have them at these hospitals. We will have, there are 5 pharmacists at St. Joseph's. So if you say 5 at St. Joseph's and 5 at Campbell River, that's 10. The registered nurses. Everything else is not, according to their definition, considered a clinical service. So by default, everything else could be privatized. Everything. So actually in their concept paper, they present, and this is slipping and sliding a little bit, but they present in their concept paper, or sorry, the project brief. They have so many documents. The project brief says that the project company will be responsible for general management, plant services, environmental services, roads and ground maintenance, including structured parking, help desk services, utility management services, housekeeping and linen services, waste management, recycling services, and pest control services. We already know that aside from this whole P3 project, medical transcription, lab, and stores are on the road to privatization if the government has its way. Privatization and centralization. So what are we talking about when we talk about a public-private partnership on the North Island? There's been an evolution of these 13 projects that Stephen mentioned in healthcare in BC. They have evolved. The first was Abbotsford. That was a pretty sloppy deal from the beginning to the end. There ended up being one bidder. There's your competition, one bidder. In the most recent project that was completed, which was the Fort St. John Hospital, and by the way, the project manager for the North Island Hospital project is a gentleman named Tom Sparrow, who was the project manager for the Fort St. John Hospital. And he's a believer. He really, really believes in this stuff. The private side of the public-private partnership is a consortium that is put together for the purpose of bidding on these projects. So this project, North Island Hospitals, is a $600 million project. The consortium is responsible for design, finance, build, maintain, operate, and this concession thing, which I don't even understand. The consortium that got the contract for the Fort St. John Hospital crosses over in its membership with the consortia that did various other projects, including the Royal Jubilee Tower. And that consortium consists of, and I'm giving you these names because watch out for them, they'll probably be the ones here too. The project management is Healthcare Project. That's a company based in the UK. The design build is Acciona from Spain, and Stuart Olson, which is an Edmonton, Calgary, Saskatoon company. The design was Canon Design, American company. Facility management services, Angus Consulting Management, which is a North American company, and it's Toronto-based, according to their website. But they hide a lot of stuff in these websites, right? If you see the name Canada after it, or Western after it, you can bet your bottom dollar that there's nothing Canadian or Western about it. And then finance, and this is taken from the consortium at Fort St. John was called ISL Health. This is from their webpage. The finance says the concessionaire for the Fort St. John Hospital project is Acciona and Innisfree, 50-50. Spain, Acciona is Spanish and Innisfree is UK. That's who's going to be designing, building, financing, maintaining, and operating hospitals in the North Island, if they have their way. So it's been said that this is an ideological question, and it is. It's an ideological question because it relates to what kind of a society you want to live in. You want to live in a society where healthcare is a commodity to be exploited by private corporations for profit, or where healthcare is considered a social responsibility that government delivers to the citizens to meet the healthcare needs of the citizens. And this is not, I'm not just sort of blowing smoke on this one. On July 28th, the Governor General was at the Olympics, and he had a meeting where he was speaking on behalf of the Canadian government to the heads of various governments that were participating in the Olympics. And he had a breakfast meeting, and it's called, and this is from the Governor General's website, breakfast meeting was called Breakfast Seminar on the Canadian Public-Private Partnership Model. And in it, he explains what a wonderful, wonderful idea this is. It's all about sharing knowledge. It's all about bringing together, he talks about the diplomacy of knowledge. And his reason for sharing this brilliant idea from Canada is because we want to participate on a world scale in the diplomacy of knowledge. And he says many things in this, well, not many, it's only 2 pages, but he defines the core business, Stephen, the core business of government as defining desired outputs. Defining desired outputs. So government doesn't actually provide healthcare, provide schools, provide infrastructure on behalf of the citizens. It defines outputs and then goes and finds the private sector partner to provide those. The private sector partner whose aim in life, especially if you look at these corporations, because they're invested in everything, from mining to IT to healthcare, they're in the business of making profits. And if it can be done in healthcare, they'll do it there. If it can be done somewhere else, they'll do it there. So, the North Island Hospital project, what stage is it at? April 26th was the announcement. June, the request for qualifications was issued. That's a 60-page document which provides a general description, including a general division of what the health authority will be responsible for and what the private consortium will be responsible for. Apparently, according to Tom Sparrow, 8 groups bid on that. The top 3 will be invited to respond to a request for proposals, which will be issued sometime within the next few months. Then there's a 9 to 12-month period during which these 3 companies will present their bids. Now, the 2 losers of the 3 will each get $750,000 for their trouble. So it's a $1.5 million out of the healthcare budget to those folks to prepare a bid. That's not even talking about all the lawyers that are working on putting these contracts together, all the negotiations, all the government folks that are going to be involved in participating in this process. Now, it says right in the RFQ that the health authority can walk away from this process at any point. That's where you come in. I'm appealing to everyone, but particularly to the healthcare workers who are here tonight, that defending public health care is not something of which one should be shy. And it really is the healthcare workers who are on the front line. When Stephen talks about the team, every one of you here that I see know precisely what that means. That if you can't rely on somebody from another department or another area to be there when you need them to support you in a formal or an informal way, then the system will collapse. And with all the pressures on healthcare now, and all the difficulties that we face in terms of workload at St. Joe's, it's that team that makes it possible to still deliver healthcare. So it's extraordinarily important that we defend the hospitals as publicly funded and publicly delivered. I want to make one more point. You got a green sheet when you came in. One side of that has all the regional directors. And the reason we've given you that is that the capital funding for these projects is divided 60-40 between the province and the regional hospital board. So the regional hospital board, which is made up of representatives from the cities and towns and the regional districts, commits 40% of the funding for this project. That gives them a say in how it's done. And it was when the regional hospital board said, we don't agree with a regional hospital, a single regional hospital in Dove Creek replacing 2 hospitals in our communities, that VHA had to make an about face. All of which, by the way, has been eliminated from their website. If you check, there's this extremely interesting document on their website that says that the history of this project is that in 2003, VHA started thinking about what to do about healthcare on the North Island, and in 2009 they came up with an idea for 2 new hospitals. Oh. Nothing happened between 2000. There were some consultations. Okay? So that body is a powerful body. They're directly elected by you. And there are a good number of people on that body that are conscientious and responsible and everyone on that body should be conscientious and responsible, and you have every right to hold them to that standard. So the information on how to contact the regional directors is on that sheet. The other side is the media. If you're moved to write a letter, to comment, there's the addresses to contact the media. And I've written myself a note, which I can't read. Whatever. Okay, so that's all I want to say. I do want to make one more comment referring to the team. The accusation is made against people who are opposing the P3 that we're scaremongering, that we're saying that, oh, it's all going to be private and it's all going to be broken and it's all ridiculous and that just won't happen. Jane Murphy, the CEO of St. Joseph's, when it was put to her that this is the definition of clinical services, excludes almost everyone that works at the hospital and provides the team services that we provide. She said, oh, well, I'm certain that VHA is not following that definition. Well, it's the legal definition. They can follow it. So to be frightened that they will is a wise thing. When Bill 29 was brought in and the government stripped all the healthcare contracts of the language that prohibited contracting out, a lot of people said, it's just an accounting thing. They're just, it's just in case, won't happen. It took about 2 years before all the housekeeping and all the food services, except for the Northern Health Authority and Northern Vancouver Island, were privatized. Now, the food services result mainly in lousy food, but housekeeping services result in death. And the Burnaby Hospital is a good example, although you can't lay all of the tragedies at Burnaby Hospital on privatization, because you also had the problem of the dysfunction of the health authority, which completely crushed their infection control program and wouldn't listen to them and so on and so forth. But we do know, there are people in the audience that have direct experience with the phenomenon that Stephen described of the nurse needing the housekeeper to drop what they're doing right now, which is washing a wall, which gets washed once a month, and come over and clean up a spill that is endangering someone right now, and the call has to be routed. This example was from Powell River. The call goes from Powell River to a call center in Vancouver, and within 100 minutes, the call center in Vancouver is supposed to have assigned someone in Powell River to clean that. If you multiply that by every department, by health records, by the front desk, by maintenance, by housekeeping, by stores, by the kitchen, just imagine what healthcare will look like. It's like an orchestra where everybody has different music. It doesn't work, it can't work, it needs to be stopped. Please sign up on the sheets. Get on the Citizens for Quality Health Care listserv. All the documents that anybody's referred to here today are available. They're all in the public domain. We have them all. We can send you anything you want as backup information. And as this process goes forward, we're going to be calling on everyone to take a stand. With the healthcare workers, I'm telling you, have to be in the front line, but the whole community has to fight this to make it go away. These things have been stopped. They've been stopped in many places. The health authority can walk away from it. And in Abbotsford Mission, there was a major project, a water treatment plant, that the federal government said this must be a P3, and the municipal government said this will be a P3, and the citizens said no, it won't, and it isn't.